Dr. Kalonji, and we did our journal club today together with the help of Dr. Jaimes. And just to get started, we have no financial disclosures. So here are our objectives today. We're using the basic objectives for our journal club with the one caveat of we will be focusing on discussing non-inferiority and superiority trials, since that was something that was featured in our study. And everything is tailored to a diagnostic study rather than a treatment study today. So with the huge surge in the use of Procalcitonin throughout the medical field nowadays, we thought it would be interesting to do our journal club on that topic, looking at Procalcitonin as a biomarker for infection. So there have been a lot of studies, or a few studies done in the adult population, and we wanted to see what was out there for the pediatric population, since there was a lot of studies showing that Procalcitonin has a higher negative predictive value as a biomarker in the adult population. And then one of the populations we thought would be interesting is the neonatal population, just because we're often doing rule-out sepsis workups on those patients and to see if there's some benefit in using Procalcitonin in that setting to minimize the use of antibiotics if possible, or any other further treatments that we do with those kiddos while they're in the NICU. And so our study today has a patient population of neonates who have a gestational age of 34 weeks or greater. And then the intervention that we're looking at is the Procalcitonin testing, comparing that to standard sepsis workup. So in this study, the standard was looking at CDC and CRP levels throughout the study. And then the outcomes that they focused on primarily was the duration of antibiotic therapy, but they also took a look at whether or not these neonates ended up getting reinfected after the antibiotics were stopped, as well as if they had died within the first month of life and the reason for that. And like I spoke earlier, this is a diagnostic test, not a therapeutic test. So the best study to look at this kind of question would be a randomized control study. So this is our article, Procalcitonin Guided Decision-Making for Duration of Antibiotic Therapy in Neonates with Suspected Early-Onset Sepsis, and it was a multi-center randomized control trial done in 2017 by Stocker et al. So, like I mentioned, it was a randomized control study that they did. It was conducted by the Neonatal Sepsis Trial Network. So there were no financial incentives given to the participants nor to the investigators who participated in this trial. And they included all neonates born after 34 weeks gestation who had suspected early onset sepsis in the first 72 hours of life. So these patients were recruited from multiple locations. So the Netherlands, Switzerland, Canada, Czech Republic, the United States was not included in this study. And this was done between 2009 and 2015. The protocols were approved by their local institutional review boards as well as the National Ethical Committee for each of those sites. So just to dive in a little more to the method, to kind of break it down for you guys. So they did first, once they had these neonates who were going to participate in the study, they classified them as far as their risk for infection. So they looked at 3 different things and gave them a point for each one. So they looked at risk factors, so they looked at clinical symptoms, and then lab findings. So the risk factors that they focused on was whether or not there was maternal DNS positive status, whether there was any concern for a maternal chorioamnitis, and so they defined that as a fever greater than 38.5, and then fetal tachycardia. They looked at premature rupture of membranes greater than 18 hours, as well as if they were less than 37 weeks gestation, so between 34 and 37. So if they had any of those, whether they had multiple of those or just one, they got 1 point. And then they looked at the clinical symptoms, if they had any type of respiratory distress or apnea, tachycardia or bradycardia, any hypotension and or poor perfusion, and then whether they had any type of thermal dysregulation, so hypothermia or hyperthermia. And then if they had any seizures or were floppy baby, or they were really irritable or lethargic. And then also if they were vomiting or feeding. So this kind of is like most of our babies up in the NICU. But for any of those, even if they had multiple, they got 1 point for that. And then they also looked at the lab findings, so they focused on a white blood cell count less than 5 and a CRP greater than 10. They had one or both of those, and they got 1 point.
So the max was 3 points?
So the max was 3 points. So once they determined that, they also got blood cultures on those babies to classify them into different categories. And so they broke the categories down into category 1 being sepsis was proven. So that meant they had a positive blood culture. And whether their score was 1 to 3, they were still proven sepsis. Category 2 was infections probable. So those were the babies who had negative blood cultures. And with that, they had a score of 3. So they had at least one of each of those categories where risk classifications were positive. And then category 3 was infection possible. And so those babies had negative blood cultures, and then they had a score of 2. Didn't matter where they got their 2 points from, but they just had a score of 2. And then category 4 was infection unlikely, and those were the babies with negative cultures and who had a score of 1 or less. So once they did that, they then went ahead and randomized their babies. So subjects in category 1 and 2 were treated with standard antibiotic course for 7 days, for at least 7 days. And this was included to reflect the clinical practice of what we basically do in the NICU or anywhere else for someone who has proven infection. And no procalcitonin levels were checked for those babies. Subjects 3 and 4 is where the randomization actually comes into effect in our study. So these babies were randomly assigned in a 1-to-1 ratio into either the procalcitonin group or the standard group. For the groups in Switzerland and Czech Republic, they did this by drawing group assignment cards. And for the infants in the Netherlands and Canada, they did this by using a computer-based block randomization program that did it in 4, 6, or 8 patients. The primary investigator was blinded to the study, but the therapeutic physicians actually taking care of these babies were not. So then, once they were randomized into their different groups, so for category 3, the standard group got 5 to 7 days of antibiotics, as you can see there in that chart, and the procalcitonin group were treated based on their levels. So, as long as they had at least 24 hours of antibiotics, once they had 2 procalcitonin levels that were within normal range, and we'll go over what normal ranges they use, then the antibiotics would stop. And then for category 4, it was the same thing. So the standardized group was treated, instead of 5 to 7 days, they were treated for 36 to 72 hours. And then the procalcitonin group went by the same protocol as long as they were treated for at least 24 hours, it was based off the levels. Any questions about any of that before I move on? And so the treating physicians, like I mentioned, were not blinded to the study, and they actually were able to overrule the decision to discontinue or continue antibiotics despite what the procalcitonin level was. So just keep that in mind for later when we're talking about the results. So there were 2 studies that they referenced in their reference section and in their article where there were prior studies looking at what the normative values of procalcitonin is in neonates. And using that as their references for when to stop, when to consider the procalcitonin level as normal, they used this graph which came from those 2 studies. So just to go a little further. So once these babies were in their group, there was the question of when to do the lab work, when to draw the blood work. So everybody got blood work done at the beginning of life when they were suspected to have sepsis. So they got a white blood cell count, a CRP, and a blood culture done. And then they were put into their designated categories and groups. And then at that point, at 12 hours of life, anybody who's in the standard group didn't get any additional lab work at 12 hours. Anyone who's in the procalcitonin group got a procalcitonin level. And then at 24 hours, the procalcitonin group got a procalcitonin level in white blood cells and CRP, and the standard group just got the white blood cells and CRP. And thereafter, they got it every 24 to 48 hours. And then once the neonates were discontinued off their antibiotics, they followed those neonates for a time period to see if they developed a reinfection within 72 hours. And they also looked to make sure that whether there was a neonatal death before the first month of life, or before the end of the first month of life. Any questions about that breakdown? So, moving on to some of the results. So, they had about 2,400 neonates that were originally included in this study. And for various reasons, such as they weren't able to obtain consent for a reason, they were ineligible for whatever, if they had like a congenital malformation or something else going on, and any other numerous reasons up there. About 700 or so were not included in the final results, and that left them with 10 neonates that were randomized into the procalcitonin and the standard group. And once they did that analysis, so they looked at all the babies in the procalcitonin group at the beginning and all the babies in the standard group at the beginning. But they also did a more specific analysis on all the babies who actually followed the exact protocol of the study. And for that, there were 755 of those babies that were in the procalcitonin group and 633 that were in the standard group. And so just to talk about a little bit about non-inferiority trials, just to remind everyone, so these are done when we want to show that a specific diagnostic tool or treatment is non-inferior to the control or standard. And generally it's done when you're not able to compare it just to a placebo. You actually have to compare it to a specific test or treatment. And generally we're doing this because that new tool or treatment is in some way more advantageous. Whether it costs less, whether there's more compliance with it, whether it's safe, more safe, are some of the reasons why we would go ahead and do that. And so when you're doing a non-inferiority trial, the null hypothesis that you're thinking of, treatment X is worse than Y for a given condition by greater than delta. And then I'll talk about delta in 1 second. And then the alternative hypothesis would be that treatment X is not worse than the treatment Y for a given condition by greater than delta when delta is a non-inferiority margin. So delta is determined by the investigators, and it's generally based off of prior knowledge of whatever the diagnostic tool is or the clinical reasoning behind the tool. And so for our study, investigators chose a delta of 2% when they were looking at the difference between the procalcitonin and standard group, looking at the confidence, 95% confidence interval. So if it was less than 2%, then that meant that the procalcitonin group was deemed non-inferior to the standard. Any questions of that? And just a summary of kind of intention to treat, because they talked about this a lot in our study as well, versus per protocol analysis. So intention to treat is when you include all of the randomized participants in the study with the intention of being subjected to the intervention and having the data analyzed. Versus per protocol is only analyzing those patients that actually follow the exact protocol of the study. And then, so just to look at one of their first tables in the study, it was just comparing the baseline characteristics of the different groups that they ended up having. And if you look across, I don't know if you guys have it in front of you because this is kind of small for you guys, but if you look at across at like sex, gestational age, birth weight, they looked at a number of different things. All of the groups all across the board were practically the same or similar. There was no significant difference in any of the groups, even when you compared the intention to treat versus the per protocol analysis, as well as when you're looking just specifically at procalcitonin versus standard. I won't go through all those numbers. And similarly, you can also see that there was no significant difference if you're looking at what their white blood cell count, the average of the white blood cell or how many participants had elevated CRP, and then the number of participants in each group who were in the different categories. So category 1 being the infection-proven group, category 2 being the infection-probable group, and so on. So overall, you can see that they did a very good job of randomizing their patients and keeping everything equal. And then what else I wanted to focus on this graph is just what antibiotics were used, because we were pulling from different facilities, and so every facility has their own unique combination of antibiotics that they like to use for sepsis. But overall, the majority of them, about 75% across the board, or I'll say 70% across the board, use the beta-lactam antibiotics, so something like penicillin or cephalosporin, with an aminoglycoside, so pretty much what we do up in the NICU. And then the rest, about 25 to 30%, use the penicillin with cephalosporin or penicillin carbapenem.
Okay, on to the results. The first outcome that they were looking at primarily was the duration of antibiotic therapy. So in the procalcitonin group, looking at the intention to treat analysis, the duration of antibiotic therapy was found to be 55.1 hours with a 95% confidence interval of 50.5 to 60 hours. Compared to the per protocol analysis, it was 51.8 hours with a 95% confidence interval of 48.2 to 56. In the standard group, intention to treat analysis, as you can see, the duration of antibiotics was 65 hours, and in the protocol analysis, it was 64 hours. The p-value for both the procalcitonin and standard group was less than 0.0001. The main difference between the two groups with regards to the duration of antibiotic therapy was 9.9 hours, so about 10 hours. And in the protocol analysis, it was 12.2 hours. So those results are statistically significant, but we'll get into the clinical significance of that later. There were no sepsis-related deaths, and less than 1% had possible reinfection. All right. Another aspect they looked at was the length of the hospital stay. So again, in the procalcitonin group, in the intention to treat analysis, the overall duration of hospital was found to be 123 hours with a 95% confidence interval of 113 to 134.5. And in the per protocol analysis, it was 115.8 hours. Whereas in the standard group, length of hospital stay in the intention to treat analysis was 126.5 hours. And in the protocol analysis, it was 121 hours. The main difference between the two groups in the intention to treat analysis was 3.5 hours with a p-value of 0.0019. Again, statistically significant, but we'll talk about the clinical significance of 3.5 hours later. And then the protocol analysis, the mean difference was 5.2 hours with a p-value of 0.0039. With regards to reinfection or death, in the procalcitonin group, there were, in the intention to treat analysis, reinfection was found in 5 out of 866 neonates, so in 0.6% of the patients. And in the protocol analysis, it was found in 5 out of 745 patients, so 0.7%. And in the standard group, reinfection in intention to treat was found in 3 out of 844 cases, so 0.5% of the time. And in the protocol analysis, it was 3 out of 663, so 0.6% of the time. There were no deaths in the procalcitonin group, and there was 1 death related to perinatal asphyxia in the standard group. Okay, so the risk difference for reinfection within 72 hours of discontinuation of antibiotics or death within the first month of life between the two groups was 0.1% in the intention to treat analysis and 0.1% for the per protocol analysis. None of the neonates with suspected reinfection in either group had culture-proven bacterial infection. So as Nicole mentioned previously, physicians had the liberty to deviate from the protocol and the recommendations, and they did so, you would say, in about a quarter of the cases in both the procalcitonin group and the standard group. So in about 89% of the cases out of 745, the physicians decided to continue with antibiotics longer than recommended, and in the standard group, they did so about 45 times out of 663, so 6.9% of the time. And they discontinued earlier than recommended in 102 cases versus in the standard group 117 times out of 663. So about a quarter of the time, as I said. And this is pretty much how real-life practice is. If you think about it, we all have protocols, but they're just there to guide your decision-making. They're not there to make the decisions for you. Physicians always have to use their clinical judgment. There was an informal analysis that showed that the duration of antibiotic therapy was significantly reduced in cases where physicians were adherent to the recommendation. So in this informal analysis, it showed essentially that there was a mean difference of 21.5 hours between the procalcitonin group and the standard group where physicians adhered to the protocols as recommended. So that is more meaningful perhaps than 3.5 hours. Okay. So now we're going to talk about the appraisal, internal validity first. Was the diagnostic test evaluated in a spectrum of patients like those in whom it would be used in praxis? And we said yes, neonates in the NICU. Was the reference standard applied regardless of the index test result? And we said yes, because everybody received a white cell count and a CRP. Was there an independent blind comparison between the index test and an appropriate reference or gold standard of diagnosis? Again, we said yes, because everybody received the white cell count and the CRP. So back to the results. The duration of antibiotic therapy was decreased by about 10 to 12 hours in the procalcitonin group. The clinical advantage of this would depend on the timing of antibiotics, perhaps. So if you were getting the procalcitonin results in the afternoon or in the evening, you could decide to send your patient home later on the day as opposed to having them stay overnight and risking an additional day's worth of hospital charges. The length of hospital stay was decreased by about 3 to 5 hours, so little clinical significance. And then you have to think as well about the added cost of the procalcitonin for 3 or 5 hours less of time in the hospital. Both can be biased by the treating physician's clinical decision, and we said this is not necessarily a bad thing. As we said, protocols are just there to guide, and physicians are entitled to use their clinical judgment. All right, now looking at the external validity. Were the methods for performing the test described in sufficient detail to permit replication? Nicole went through the methods, and I think we can agree that yes, they described it in sufficient detail. And can I apply the results to my patients? We said yes. So were the study patients similar to my patients? If you're talking about the NICU, yes, except that they excluded preterm neonates, so they didn't use those under 34 weeks. And were all patient-important outcomes considered? Again, yes, they looked at the length of the duration of antibiotic therapy, the length of hospital stay, as well as reinfection or death. Other likely advantages of the novel diagnostic tool were the potential harm and cost. So we said potentially. It does not require additional blood draws compared to current guidelines or clinical practices. It could decrease potentially the length of stay of neonates who is only in need of a rule-out sepsis workup, and it could decrease the time of antibiotic use and the development of microbial resistance, which would offset the added cost of the procalcitonin test. So some of the things that we discussed when looking at this study was procalcitonin-guided decision-making can potentially lead to a reduction in the duration of empiric antibiotic therapy. It can lead to a reduction in the length of hospital stay. There's a minimal risk associated with it, low risk of reinfection and no study-related mortality. It could potentially help with antimicrobial stewardship and reduce the rate of increase in antibiotic resistance. So looking at some of the limitations, the study did not include any preterm infants that we frequently see in the NICU. And a confounding factor was that all neonates with suspected sepsis were included, some of which had additional problems for being in the hospital. So the length of stay of a neonate could be affected by the fact that they were preterm or had low birth weight, they had feeding difficulties or hyperbilirubinemia. All that would affect the length of stay. All right. Do we have any questions?
Any idea what the cost of Procalcitonin is?
I tried to find out. I actually did try to find out, and then Billy kind of put me through a thing that I didn't want to go through.
Anybody have questions on the non-inferiority trial? So one thing that I just want to make sure that everybody understands, this is a randomized controlled trial, even though it's a diagnostic study, right? So they're not proving treatment. They're just trying to classify or saying whether procalcitonin as a tool is a good tool to use as a diagnostic tool, right? So it's a randomized controlled trial, but it's a diagnostic tool that they're trying to evaluate, right? So just to understand, because when Nicole was explaining, she's using the terms of therapeutic, right? So I just want to make sure you get that it is a trial, but it's a diagnostic tool what we're trying to evaluate here, okay? Did everybody understand what the index test was? What they mean with that? Can anybody tell me what the index test was? If you don't know, then we didn't understand anything. I want one person to tell me what the index test when we have these questions. What was the gold standard? So what was the index one? The index one. The procalcitonin, exactly. So the gold standard was the CBC with the CRP and the index or the test that we're trying to evaluate is the procalcitonin, right? So all those questions have no sense if you don't get that. Okay. What about the concept of per protocol versus intention to treat? You get why is this important? So the reason why you have to do both in diagnostic studies is because you have to see what is the real effect, which would be the intention to treat, and what is the ideal effect. That would be per protocol, right? So if you follow the instructions as we are saying or as we're proposing, your time without antibiotics will be, say, 12 hours. But if you change the protocol or something else happened or you decide to prolong it because it's your clinical impression, whatever, then the time will be 9.9 hours. See? So what is the max effect would be the per protocol, and what is the true effect would be the per intention to treat analysis. Okay? So one thing I just want to say, because of a matter of understanding this, the reason why we put this in here, right? This is the different values on the important possible confounding, right? After scores, vacuum delivery, MAMS, GBS positive or not, and then you have the randomization of the different groups. If so, all these factors are equally distributed, right? When you do an intention to treat analysis, you're keeping randomization, and that's why you have to do an intention to treat analysis. When you have to do a per protocol analysis, you might be modifying those different confoundings, right? That's why they have to give us this data. So whatever per protocol population they have left did not vary much on the distribution of the risk factors, okay? So they have to give us this data because they're still doing this per protocol analysis anyway, and we're making some conclusions of it. If by the per protocol analysis you notice that something is extremely different one from the other. For example, the GBS positive status. Then you know that this population is not equally distributed. There are some, like, group B babies that are going to be more or less affected by these protocols, right? So your conclusions cannot be the same. When they compare the two groups and the randomization maintains, then you can, in a more trustable way, trace conclusions of the per-protocol analysis, okay? That's why you have to have the two analyses. Did I explain myself well, or I got you confused?
So, a lot of times in these studies, a lot of times I'll see the intention to treat is there, and they don't even analyze the patients that are fall out. But in this one they did, and that's what you were just talking about. And is that because of the study design? Because a lot of times the per protocol analysis is, I've not seen that. Is that because the particular study design is what you're saying?
So that gives the study strength. So the study design is better when it has the per protocol analysis. It should be there. And in an intention to treat analysis and per protocol analysis should always be there when you're doing a non-inferiority trial. So now on, because remember, usually we use superiority trials, right? This medication or this diagnostic tool is better than nothing. So placebo, right? But now that we do have diagnostic tools, we cannot compare with nothing. We have to give the kids what we already have, the CBC and the blood culture, right? So you have to compare with something, and that's why we use a non-inferiority trial. For non-inferiority trials, and you're going to see this more and more and more because epidemiology has changed, because medicine has changed, so we're not comparing to placebo anymore, we're comparing to something, right? So you're going to see more non-inferiority trials as we keep on advancing in medicine. And one of the things you always want to have is the two analysis, the per protocol analysis and the intention to treat analysis, okay? And always, at least the intention to treat analysis should be there, otherwise don't read the article. Yeah, if you're only analyzing the per protocol analysis, you're just biasing everything. So it has to be, the intention to treat analysis has to be there. And more for non-inferiority trials, if you want to really prove what's the real effect that you want to bring up to science, you do the per protocol analysis, but you always present both data to make sure that you keep your randomization and the real life component of it. Okay? Always try to look for articles that have both. So it is a strength of this.
So how are you showing the randomization is maintained?
Because of these data.
You have both tables.
Sorry. Yes.
So theoretically, the randomization could have gotten botched up, and it would have been shown right there.
Exactly. Theoretical, if we have a problem with the randomization because of the population just itself deviate from the randomization because of whatever characteristics are, and you have a protocol analysis which baseline characteristics are very different than the intention to treat one, then you know that the randomization was not maintained, so the conclusions of that study on the per protocol analysis might lose